Myelodysplastic neoplasms (MPN) pathology. There is slow proliferation of terminal myeloid cells, mature cells, of multiple lineages RBC, platelets, neutrophils, eosinophils, baudophy, monocyte. No dysplastic or immature cells seen. Classification of MPN. 1. Polycythemia rubra vera. 2. Primary myelofibrosis. 3. Essential thrombocytosis. 4. Chronic myeloid leukemia. 5. Chronic neutrophilic leukemia. 6. Chronic eosinophilic leukemia. 7. Juvenile myelomonocytic leukemia. 8. MPN not specified otherwise. What's polycythemia? Hemoglobin, greater than equals 16.5 males. Greater than equals 16 females. PCV, greater than equals 49 males. Greater than equals 48 females. Types of polycythemia. Relative and absolute. Absolute is further of types primary and secondary. Relative polycythemia etiology and investigation. Due to decreased plasma volume, so HB-conc increase. Or post-viral like dengue due to decrease in intravascular volume. Investigation. RBC mass normal, HB high, total count normal, platelets count normal. No treatment, just drink water more. Relative polycythemia is aka Gaze-Bach syndrome. Absolute polycythemia. RBC mass is increased here. Primary is due to MPN. Secondary is due to increased erythropoietin. Causes of secondary polycythemia. 1. Hypoxia, COPD, OSA, high altitude, county intoxication, hepatopulmonary syndrome. 2. Renal artery stenosis. 3. Perineoplastic renal carcinoma, cerebellar hemangioblastoma, meningioma, pheochromocytoma, uterine fibroids, hepatoma. Primary polycythemia aka polycythemia rubra vera. Etiology, age and gender. Etiology, JAK2 mutation in 100% PT. Exon 14 in 95%. Exon 12 in rest 5%. Age 50 to 60 year. Gender F greater than M. Clinical features of primary polycythemia. 1. Erythrocytosis. 2. Granulocytosis. 3. Thrombocytosis, bleeding by acquired von Willebrand disease. 4. Erythromelalgia, burning pain of feet hands cause of microvascular thrombosis. 5. Splenomegaly mild. 6. Hyperuricemia cause of increased turnover of cells. Erythrocytosis in primary polycythemia, what features it produce? 1. Hyperviscosity symptoms, vertigo, dizziness. 2. Thrombosis, if it's arterial causes stroke in youngs. If venous, Budd-Chiari, DVT. If microvascular, erythromelalgia. 3. Hypertension. Granulocytosis in primary polycythemia, what features it produce? 1. Neutrophilia. 2. Basophilia, mast cells release histamine, it causes aquagenic pruritus after bath. 3. Mature granulocytes, increase transcobalamine 1 so Vit B12 binding capacity increase. Investigation in primary polycythemia or polycythemia rubra vera. 1. RBC increased. 2. MCV less, MCH normal. 3. ESR low, decreased rouleau formation. 4. Leukocyte alkaline phosphate high, from mature neutrophils. 5. Vit B12 binding capacity increased. Management of polycythemia rubra vera. If low risk, age less than 60, then phlebotomy plus aspirin. If high risk, phlebotomy aspirin plus JAK inhibitor, ruxolitinib, or hydroxyurea. Which is most common type of MPN? Polycythemia rubra vera. Primary myelofibrosis (PMF) and secondary myelofibrosis. Etiology. Primary myelofibrosis. 3 mutations. 1. JAK2 50% only. 2. Calreticulin CALR. 3. MPL gene mutation. Deletion on chromosome 13. Secondary myelofibrosis aka myelophthisis is a bone marrow failure, it's not a MPN. Primary myelofibrosis (PMF). Pathogenesis. Hypercellular marrow produces dysplastic megakaryocytes, lack CXCR4 receptors. They release TGF-beta, which causes fibrosis of marrow type 3 collagen. So premature cells are pushed out of marrow and there is pancytopenia. Clinical features of primary myelofibrosis. Age greater than 60, M equals F, thrombosis, massive splenomegaly, fatigue, anemia due to pancytopenia and bleeding, erythematous papules and plaques, gout. Investigation in primary myelofibrosis. 1. Bone marrow biopsy by silver impregnation show reticulin fibrosis plus collagen. 2. Peripheral smear, teardrop cells, leukoerythroblastosis, thrombocytosis, cloud-like megakaryocytes. 3. Serum type 3 collagen increased. 4. Massive splenomegaly. Management of primary myelofibrosis. Median survival of 5 years, bad prognosis. If JAK2 mutation, ruxolitinib. Definitive treatment, transplant AHSCT, allogeneic hematopoietic stem cell transplant. But it should be a complete match. Essential thrombocytosis (ET). Etiology, age, gender. In ET, only megakaryocytes hyperplasia is there, RBC-WBC are normal. JAK2 mutation, CALR mutation, MPL mutation, age 50 to 60 year, F greater than M. Essential thrombocytosis clinical features and investigation. RBC-WBC normal. Platelet count greater than 4.5 lox. Bleeding and thrombosis. Bone marrow biopsy shows staghorn cells, giant megakaryocytes with mature cytoplasm and hyperlobulated nuclei. Essential thrombocytosis diagnosis. Diagnosis of exclusion. Essential thrombocytosis management. In low risk, aspirin 75 mg per day. High risk, aspirin plus hydroxyurea greater than interferon greater than anagrelide.